We'll do that one next. All right, so this is one of my favorite topics in medicine. So pulmonary thromboembolism, or PE, or pulmonary embolism, however you want to name it, it's one of those things that if you do critical care, emergency medicine, surgery, internal medicine, family medicine, OBGYN, it's going to catch you and it's going to burn you. You're going to miss one. It's going to happen. All right. So these are very, very difficult to diagnose. And the reason being is that it presents with so many different heads, so to speak. Top three differentials of pulmonary embolism is simply anxiety. All right. So it is very, very difficult to be able to diagnose. And you would think of somebody that has chest pain, shortness of breath, dyspnea. Oh, well, it's classic. Sounds like a pulmonary embolism. But it could be so many other things, right? So it could be asthma. It could be aortic dissection. It could be pneumonia. It could be anxiety. It could be MI. It could be pericarditis. It could be reflux. It could be so many different things. So we have to start training our brain in that critical care setting to kind of analyze these patients and see where they kind of fit in categorically. And it's very, very hard. You know, your patients are walking, talking, look great, just saying, yeah, you know, I got this vague chest pain. I've had it for 4 weeks and I get short of breath sometimes. And you give them a nebulizer treatment there and they're, okay, I feel better. All right, have a nice day. And the chest x-ray looks fine. And then the next day you get a call that the patient's in ICU with an embolism in their chest. So it's very, very hard. And the longer you practice medicine, the more in tune you will be to picking up these things. And I'll tell you that, you know, this is a crazy story, but I had somebody, you know, it was our 4th day in the emergency room in the city with me. And I wasn't on that day. She just graduated. It's her 4th day working. She's still under probation because you have a probationary period before you cut loose to practice on your own. And she got an 18-year-old female that came in, inner city, chest pain, shortness of breath, x-rays normal, put her on Zithromax, sent her home, and they found her dead the next morning. So she died. She was dead the next morning, and the family didn't only try to sue her. The family went after her to take her license away, called Office of Professional Medical Conduct, all right, for neglect. So she didn't lose her license, all right? It settled out. She didn't lose her license, but I can assure you from that point on, everybody that came into that emergency room, doesn't matter if you had pink eye, she was ruling you out for PE. Like she couldn't get past it. And it haunted her for years to the point where she was like, I can't do this anymore. Because she couldn't get by it. Now it's a very, very crazy story, but it does happen in that scenario where you will miss things that look like bronchitis, and it's not. And this is one of those things. Over 500,000 deaths, 50,000 deaths per year, 500,000 cases at least every year. We find them incidentally. We find them on purpose. We have to really kind of listen to the patient to dig deep to see what's going on with these patients. But look at this little caveat here. 3rd most common cause of hospitalized deaths. So it's not that uncommon. We see these all the time. And they range. They range from massive to very, very tiny. And the diagnosis is missed up to 66% of the cases. It's the top 10 most commonly missed diagnoses in the emergency room. All right, so it's very, very subtle. It has multiple different faces in which it presents. And again, you will miss it. You know, I've missed them before, and I do critical care in pulmonary. That happens, you know, because it just presents so crazy. You know, for example, I saw somebody in the office that had shortness of breath for like 4 weeks. Obese female, gets worse every time she thinks about her finances. She gets stressed out. She gets palpitations and chest pain and shortness of breath. Not on birth control. Not a smoker. Younger. EKG, sinus tachycardia at a rate of 105. Chest x-ray clear, satting at 97%. Next day, she calls me up. I can't even walk to my bathroom without getting short of breath. Put her in the CT scan machine, multiple PEs on both sides. So it happens. Like it's crazy. But you will have to be very in tune to what your patient's saying. So Virchow's triad. You familiar with this? All right. So this is one of those things. So endothelial dysfunction. That means anything that can cause endothelial membrane to cause a hypercoagulable state. stents being placed, AV malformations, trauma, which can also cause endothelial dysfunction, hypercoagulability. Some of you could be hypercoagulable right now. You never even know. All right. What's the most common genetic hypercoagulable state? Nope. That makes you bleed. Anybody here with sickle cell? Not too common. Happens, but not common. I mean, kind of common, but not this. Factor V Leiden. You ever hear of it? The most common genetically linked hypercoagulable state. Some of you could be sitting here right now and be factor V Leiden positive, and you wouldn't know it. You won't know it until something happens, or you're like, you know what? I want to be checked. My mother and my sister had this genetic clotting abnormality. I want to be checked. And then we check you. And then you come up positive for factor V Leiden. How do we treat you? We don't. This is how messed up medicine is. We don't treat you. Maybe we put you on aspirin. Maybe. But why don't we treat you? Because the risk of the anticoagulants is higher than that of you getting a clot. Now, if you did get a clot and you have a history of factor V Leiden, whether it's a clot in the brain, in the heart, in the lung, in the lower extremity, you'll probably end up on lifelong anticoagulation. But, you know, do we want to maintain people on lifelong anticoagulation if we don't have to? No, there's a very high risk of bleed, right? We always worry about bleeding in the gut. We worry about bleeding in the brain. So we try not to if we don't have to. Stasis. So think about stasis. Patients that sit in bed all day in the hospital, is that stasis? So are they at risk for a DVT? Are they at risk for PE? Most common cause of PEs are usually DVTs, whether it's in the upper extremities or the lower extremities. So post-op needs. Anybody into orthopedic surgery here? Nobody's into ortho in this class. Usually it's like half the class. So post-op fresh knee. They're up walking that day. Bypass. You open up somebody's chest, you bypass it, you get them up that day. Later on that day, you extubate them, they're doing well, get them sitting in a chair. From the chair, you want them walking. Why? You don't want stasis. Fresh hip is done. You're going to anticoagulate them, you get them up later on that day. Or if it's a late surgery, that morning coming up. Get them up and walking. You don't want stasis. Stasis is bad. It leads to clots. The other things that we can control, and we can control this too, but the other things that we can control, surgery greater than 30 minutes. Anybody here ever been in the OR? Right? You have compression stockings on them. So anybody greater than 30 minutes is stasis, hypercoagulable state. Stroke, heart failure, any long bone fractures, pelvic fractures. So fracture of the humerus, fracture of the pelvis, fracture of the femur. All those things are increased risk of clot formation. Birth control pills increase your risk. So really, it comes down to any hormone replacement therapy. Now, this is being very challenged right now. As of today, this is a very challenged subject. That hormone replacement doesn't increase your risk. It doesn't increase your risk of MI. It doesn't increase your risk of stroke. It doesn't increase your risk of cancer. It's very, very debatable. But as for clotting, if you're predisposed to clotting, birth control will increase your risk of clotting. So if you take birth control, you're at slightly increased risk. If you smoke, that increased risk goes fourfold. So I tell people, you got to choose one. You either smoke or you don't get pregnant. Which one do you want? It's up to you. And it also goes for male hormone replacement. So if you're on testosterone therapy, it can make you hypercoagulable. You have to be very, very careful. Now, are we talking about arterial or are we talking about venous hypercoagulation? Venous. So if you understand the anatomy, venous in the lower extremity goes up through the superficial femoral. Then it goes right into the junction of the groin, the femoral junction. From the femoral junction, it goes into the inferior vena cava. The inferior vena cava goes into the right atrium, right ventricle into pulmonary artery. And you know that we have two pulmonary arteries, right? It bifurcates left and right. Right? So you go to the left, you go to the right. So it depends where that's going to float. Now, if that clot ends up getting clotted right at the bifurcation, at the fork, that's what we call a saddle embolism. All right, that saddle embolism now starts to grow and it includes blood flow to the lungs. Now you've cut off the left and the right. So do you think it's got a very high morbidity and mortality? Yeah. So if you have a 2 millimeter pulmonary embolism that floats into the right lung, and it goes into the segmental branch, then it goes into the subsegmental branch, is it going to be a high morbidity and mortality? It's not. It's not. It's a very small, low mortality type lesion. Some people, they're so small, and our radiological procedures are so good now that we pick these things up at 1 and 2 millimeters. And we pick them up incidentally. Some people they're like, what are you talking about? I got to pee. What do you mean? I feel fine. They're satting well. They're not tachycardic. They're not coughing. They're not short of breath. You just picked it up asymptomatically. A lot of patients, the study says that more than half the patients have had PEs in the past and just reabsorbed them. It's when they get too large, they cause obstruction, and that's where you start having your issues. Cancers cause hypercoagulable states. So go back to that second story I told you with the female. She got short of breath when she thought about her finances. She had multiple bilateral PEs, small bilateral PEs. Put her in the hospital looking for the cause. Hypercoag workup is negative. CT abdomen pelvis Dopplers of the lower extremities negative, upper extremities negative. What's the cause? The only other place to look for is in her brain. So I CAT scan her brain. She had a lemon sitting in her brain. She had glioblastoma. She didn't know it. So it caused her to become hypercoagulable. So malignancies cause hypercoagulable states too. Somebody said DIC over here. Malignancies also cause DIC as well, which is the opposite. They bleed everywhere, their eyes, their skin, everywhere. So it's actually the opposite. If you had to choose one, you take the PE over the DIC anyway. Indwelling central lines, we put them in. We put in central lines all the time, right? They clot at the end. Those clots get loose, they fly right off. Now, they're venous catheters. When they fly off and they're going into the internal jugular to the superior vena cava, that superior vena cava dumps right into the right atrium. When that clot flies off, it goes right into the pulmonary artery. So it can happen. That's why if you ever try to flush a central line and you can't flush it, don't force it. If it's obstructed, don't force it. You're just going to push a clot off. What I do is I just take a teeny tiny bit of TPA, which is a clot busting drug, squirt it in there, and it's gone. It's gone. Works very well. Genetic risk factors. Now, I told you, factor V Leiden is the most common genetically linked hypercoagulable state. You should probably know that. We mentioned it like 3 times. It's going to be on tests. It's going to be on the boards. But there's a bunch. Now, some are much more potent than others. Factor V is very, very common. Antithrombin 3, protein CNS, not as common. Prothrombin gene mutation, not as common. Anticardiolipin antibody, and lupus anticoagulant. Here's a little caveat. You don't have to have lupus in order to have lupus anticoagulant. Women that have habitual miscarriages. Maybe you know some people that have been pregnant 3 times, lost 3 pregnancies. Pregnant 4 times, lost 4 pregnancies. Look into this. Look into genetic clotting abnormalities. Factor V Leiden, lupus anticoagulant, anticardiolipin antibody. It's very commonly the cause. You know how you treat it? When you become pregnant, they put you on Lovenox and you hold on to the pregnancy. It's simple. Embolization. So most of your patients are going to end up with PEs from some other site. So it comes from the deep venous system of the lower extremities and of the upper extremities. So when you're rounding on somebody and you're rounding and you see that their arm is twice the size of the other, get a Doppler of that arm. They've been sitting there immobile, plus having a catheter in their arm possibly, that are prime site for a clot formation. So you can easily catch that and treat that before they end up with a PE. But if they do end up with a PE, always check their lower extremities, specifically the lower. Okay, because the majority of your patients that end up with PE will most likely come from the deep venous of the lower extremities. Now, to get even more nitty gritty, you have a lower risk of embolization if you have a clot below the knee, a DVT below the knee. You have a higher risk of embolization when it's above the knee. And you can even have superficial phlebitis. Do you know what that is? So superficial phlebitis is when the superficial vessels clot. If it's within 1 centimeter of the femoral junction, you have to treat it as if it's a DVT. Usually we don't treat superficial phlebitis. We use anti-inflammatories or aspirin warm compresses, and it goes away on its own. If you have a superficial phlebitis, and it's within 1 centimeter of the femoral junction is the deep venous system, you treat it as if it is a DVT because the risk is so high of embolization at that point. So again, 90% are going to arise from the lower extremities. Huh. Any questions so far? So what can embolize? Well, obviously, thrombus, right? So people that have hypercoagulable states, we don't know why this happens, but it happens. They form these DVTs, and they can embolize. Air. Whenever you're pushing into a central line, whether it's a subclavian, whether it's a PICC line, even an IV, or a central line, whatever it may be, femoral line, which we try never to use. If you push air into that, what did you just do? You just pushed an air pocket into the venous system. Where's it going to go? It's going to go into the lungs. So you can actually cause this. So be very, very careful when you do this. Amniotic fluid. So the women that end up in ICU after labor are usually due to a couple of things. One, you can't stop their bleeding because they end up in DIC. DIC is disseminated intravascular coagulation. Have you guys learned about this? So DIC is this bleeding abnormality. I mean, I can get really granular with it, but since you brought it up, DIC is this clotting abnormality where fibrinogen breaks down, and there's so much fibrinogen that the macrophages can't go around and clean it up. That fibrinogen that's broken down is toxic to the blood vessels. It necroses the blood vessels. So you just bleed everywhere. All of your organs start bleeding, eyes, ears, tissue. You bleed everywhere, and it's very, very difficult to control. But anything can cause DIC, and this is not on the test, by the way. Anything can cause it. Sepsis, trauma, prolonged birthing is trauma, malignancy. So anything can cause it. So you see those women that go into ICU. You also see women that have prolonged birthing, and they end up with PEs from amniotic fluid. So they end up in ICU also. Fat. How does fat embolize? Nope, because that's arterial, right? So we're talking venous. So think about your patient that's in like a traumatic car accident and they get a mid-shaft femur fracture. Is the femur surrounded by a bunch of vessels? Loaded with vessels, loaded. So that mid-shaft femur fracture actually shears some vessels. What's in the thigh? A lot of fat. Fat actually gets sucked into the vasculature and embolizes into the lung. They look the same, they present the same, for one exception. Fat emboli usually is seen with a petechial rash about 48 hours after, where regular PEs don't. And of course, septic emboli. So you have a IV drug abuser. IV drug abuser, where are they most common to get endocarditis? On the right side of the heart or the left? Think backwards when you're thinking about plumbing in the heart. Do you inject drugs into your artery or your vein? In your vein. The vein gets fed by what? What side of the heart? So where does it lead to, though? Goes to the right side of the heart. So they are more prone to endocarditis of the tricuspid and the pulmonic valve. Endocarditis is a growth of bacteria. We see it in IV drug abusers all the time. All the time we see it. And they will be on IV antibiotics for weeks on end. When that vegetation gets too unstable and it breaks off, it goes right into the pulmonary artery. Tricuspid or pulmonic, all on the right side. It's usually tricuspid because that's the first valve affected. So septic emboli can also embolize. So what causes do we see? This is kind of like a common sense thing. If you kind of think about it, if you clot off part of the lung, what's going to happen? Well, are your alveoli going to work well? No, when they don't work well, what happens? They collapse, so you can get atelectasis. So atelectasis on a chest x-ray, you could see. So atelectasis is caused, it's not a collapsed lung, it's collapsing of the alveoli sacs. Any obstructive disease can cause atelectasis, mucus plugging, PEs, masses in the chest, you name it, it can cause atelectasis. But if you collapse those alveolar sacs, you also have impaired gas exchange. Now, you guys didn't lose blood gas, you didn't learn blood gases yet, so we're not even going to go down this road. But when you have pain in your chest and you can't breathe, and your oxygenation and your ability to gas exchange is thrown off, are you going to hyperventilate or hypoventilate? You're going to hyperventilate. So your patients with PEs are typically tachypnic. And if you're putting strain on the right side of the heart, does their heart rate typically go low or does it increase? So they're typically tachycardic. Now, the lung is very, very sensitive. It's got a somatic type pain, means it's pinpoint. It's a pinpoint pain. You know, when you get cardiac pain, your patients say, I have chest pain. And they feel it in here, they feel it in their neck, they feel it under their arm. They're like, I have this pain, I have this heaviness, I have this pain. Your patients with PE are like, I have chest pain. I feel like I have a dagger in it's right here. I have chest pain. They know exactly where it is. So the pain is very specific. It's extremely specific. The way I like to equate that is, have you ever gotten sand in your eye or something in your eye? You know exactly in your eye where you feel it and it hurts. It's pinpoint exact pain. You know exactly where to look. It's just like that. When you have just a regular stomach ache, it's visceral. It's all over. It's just, oh, my stomach hurts. But or chest pain, but when you have PE pain, it's direct pinpoint pain. Usual cause of death, right ventricular heart failure. Cause of sudden cardiac death. Why? So that pressure, that gas exchange, that resistance to pump against causes increased right ventricular pressure, which causes sudden cardiac death. So if you think about it, if you include the tiniest small vessel in the lung, in the pulmonary artery, is it going to be a problem? Most likely it's not. Could you be symptomatic? Yeah. Are you going to live? Probably going to live. If you occluded both sides, what's your right ventricle going to do? It's going to strain to pump against, you're occluding both pulmonary arteries now. It's going to strain to pump against that. So you cause right ventricular pressure and it goes into arrhythmia and you die. So if you think of it on those lines, it's fairly easy. But again, extremely easy to diagnose. This bullet right here is important. So no single sign or symptom should lead you into the direction. You have to take this as a whole. Look at it from far away and say, all right, this patient's complaining of chest pain, they're tachypnic, and they're tachycardic. Those are the three most likely symptoms and signs that they will either complain about or that you will see. The symptom is the chest pain. The sign is the tachypnea and the tachycardia. They can't control that. Right? So, but you're going to see that. So when I told you about that woman that had the bilateral PEs, little, she had the normal chest X-ray. She was satting normal. What was abnormal about her? Remember EKG? Sinus tachycardia, heart rate 105. Little tachycardic, but it is tachycardic. If your heart rate is 65, do I think you have a PE? I'm less likely to think that. But how accurate is it? Well, when you take the antimicrobial exam, check your heart rate. Let me know what it is. It's going to be high. So, but again, there's that anxiety thing. You ever see somebody have a panic attack? They're rapidly breathing, the heart rate's through the roof, and they complain of chest pain all the time. Or they pass out, or they're lightheaded. So it looks just like it. Looks just like MI. They all look alike. That's why it's very difficult to diagnose. So use this last bullet. Always use chest pain, tachypnea, and dyspnea. You're going to cover 97% of the cases. What about syncope? What is syncope? Pass out. Would you pass out with this?
You drop dead. You're not getting enough light.
Exactly. So if we have if we have an intermediate or submassive, or we have a massive, they're all going to present differently, right? Is your pressure going to be changed? It may not be. Or you could be very, very hypotensive. If you occlude both trunks of the pulmonary artery, are you going to perfuse? You have nothing on the right side. You're not perfusing. So you're going to get hypotensive. That's called a major PE. That has a very high morbidity and mortality. You don't have to write that. Don't worry about it. I'll tell you when to write it. So again, use these in conjunction. Pleuritic chest pain. If you touch the pleura, it's extremely painful. Extremely painful. So if you probably haven't. Maybe on TV, you saw somebody getting a chest tube put in ever? You sedate them and they're still moaning and trying to turn in pain. It's extremely painful. All right. If you do a VATS procedure on somebody and scrape up their pleura post-operatively, they're in a lot of pain. It's like scraping your eye. Have you ever had a corneal abrasion? People are like dying from this little scratch on their eyeball. It's extremely painful. So same exact thing. Anxious, tachycardia, low-grade fever. Why? Because of infection? No, not at all. It's an inflammatory response. So it's an inflammatory response for you. What's JVD? Go ahead, what's your question? Huh? So I want you to hold that question. It's a great question. And this is how a lot of people miss it. So you shoot the chest x-ray, the patient's got tachypnea, chest pain, tachycardia, they're sounding a little low, maybe 92, and a non-smoker. And you're like, oh yeah, I definitely hear it in there. And you take their history and they're on birth control, and maybe they socially smoke, or maybe they don't smoke at all, but the chest x-ray's got a pneumonia, and you're like, all right, yeah, take some antibiotics, whichever you guys want to give. That's up to you. And go home. Could there be a PE under that? And there could be. So we're going to go further into it, but that's how people miss it. They're like, oh, well, it's obvious. It's just a pneumonia. Have a nice day. Do antibiotics treat PEs? No, you'll kill the bacteria and they'll die from the PE. So there's things to look into for that. And that, again, that just proves my point how hard it is to make the diagnosis. Hemoptysis. All right. So about 13% of your patients will present with hemoptysis. So, but that hemoptysis is typically not just like, oh, look, I'm coughing up blood. I feel great. You know, it's usually not that. It's usually that they're also tachypnic, tachycardic, chest pain, the whole nine. Think about this. If you occlude a vessel, what happens to the vessel? In necrosis, it bleeds. That's where the hemoptysis comes in. Rails can form. We spoke about this. Fourth heart sound, circulatory collapse, and this is where you start to get a little anxious. These are the people that die on you very, very quickly, is with circulatory collapse. And we'll talk about this. Labs. So let's get into the workup of this. So maybe you're like hemming, hawing, and you're like, oh, maybe it is a PE, maybe it's not. So here's my only word of advice on how to treat patients to you. I will never tell you how to treat patients, except for this. If you're second guessing doing something, don't second guess it, just do it. So if you're like, could this be a PE? I don't know. Well, check it out. Look into it further. All right. So EKG, usually normal. If anything, you're going to see sinus tachycardia. But also there's something called the S1Q3T3. Have you guys heard of that? This is not commonly seen. Did you do EKGs yet? One class? Who's teaching it? Oh, good. So on EKG, in a very, very few amount of patients, it's not the norm. Please know that this is not the norm. You could see an abnormal S in lead 1, an abnormal Q in lead 3, and an abnormal T in lead 3. This looks like a foreign language to you. I get it. But this is lead 1, and this shouldn't be here. That's the abnormal S. This is lead 3. That's a large Q and a flip T in lead 3. That's an S1Q3T3. That's like pathognomic for a PE. It's not the norm, though. Most patients actually don't have it. But they love to ask you this when they pimp you on rounds. It's going to be on the boards. It's going to be on the test. The most common thing that you're going to see is tachycardia on an EKG. You could see nuance at right bundle branch block. You could see nuance at AFib. Bless you. But if you see this, think about it. Getting back to what you were asking, well, your patient's got a pneumonia and they have all these things. What else should we do? Well, you did this in lab medicine, right? You did D-dimers. You didn't do lab medicine yet?
Yeah, Thursday.
Who's teaching it? So D-dimers are a great test. All right. And they basically look at and measure the amount of cross products that are broken down. And that's the clotting factors. But they're supposed to break down. But how much of that is in our bloodstream? So it's very, very sensitive to pick up clotting, but it's not specific. So a very sensitive test, but not specific, kind of leaves you like, if it's sensitive and specific, then it's great. So for instance, let's take I don't know, throat culture. You guys know throat culture. It's sensitive to pick up group A beta hemolytic strep. And it's specific for that bacteria. Troponins, are they sensitive? They're very, very sensitive. That's an enzyme for heart issues. They're very, very sensitive. Is it specific? Well, endocarditis can cause it, pericarditis can cause it, cardiac tamponade can cause it, non-ST elevation MI can cause it, ST elevation MI can cause it, aortic dissection can cause it, sepsis can cause it. So I just rattled off 10 things that can make it rise. So it's sensitive for heart, but it's not as specific. It's actually the most specific blood marker that we have for heart muscle. But a lot of things can send it array. Same thing with this. All right. So for instance, for your patient, pneumonia, you're worried about it? Do the D-dimer. D-dimer is elevated. It means you have to look into it further. What if your patient that has a pneumonia had abdominoplasty, a tummy tuck 2 weeks before? Is it going to be high? There goes your sensitivity, your specificity. I'm sorry. It's sensitive for clotting because you should clot because you're healing from that abdominoplasty. But is it specific? No, it's not.
Be at risk because they're part of like.
I'm sorry, I got a fan in this thing. I can't hear you.
Aren't you at more risk because of Burko's triad? You just had surgery, so a traumatic event.
Absolutely. So you're definitely at risk. But with that risk, how accurate is this test? That's the question. So you just had surgery. Is this going to be an accurate test? It's not accurate. It's going to come back high. So you can't put stock into this test. Now, what if you were a 25-year-old, non-smoker, not obese, no history of clotting abnormality. You don't take birth control pills. You're very active, and there's no history of DVT or PE. And you come in with chest pain and shortness of breath. Is that now an accurate test? So it is, right? You don't no prior surgeries recently, so that's a good test. So if that were you to come in to see me, and I did this testing in the emergency room and it was negative, by all means, we don't even have to work it up any further because you're extremely low risk. But if you weren't low risk and you were anything higher than low risk, then the D-dimer is out the window. It doesn't matter. Doesn't matter. Just like you said, she's at high risk for PE because she had a surgery. This D-dimer doesn't even matter.
Why would I need to test everyone always anytime they come in for any?
With what? D-dimers?
Anything, like if anyone ever comes into the emergency, I don't just test them for a PE just because like why not? If it's so common as possible.
We could definitely, absolutely entertain that. And I'll tell you that it most likely happens if you come in with shortness of breath and chest pain. It's probably going to happen that they're going to rule you out for PE.
Your D-dimer is low, then there's no chance you're having.
Most likely, but you can't. First of all, you always treat the patient, never the lab. So if you put it together where they have low risk and the D-dimer is negative, you can actually stop right there. But let's say you had the abdominoplasty 2 weeks ago. Do you even need to get the D-dimer? It's useless. Like you said, now work them up. Just scan them. So you have to be able to kind of navigate the water a little. Chest x-ray, is it good for this? Well, let me ask you this. Does chest x-rays show vessels very well? Not really. Not really. And that's what we're concerned about, right? Venous vessels. So not really. So you can't put a lot of stock in this. Atelectasis, 68% of your patients. Anything can cause atelectasis. So again, non-specific finding. I would know these elevated hemidiaphragm, non-specific finding. A lot of people have it. Pleural effusion, which we're going to talk about. I vomit over how many consults I get over pleural effusions every day. Extremely common, but you have to entertain it. Westmark sign, I want you to know this. You may never see one in your life. I want you to know. They're going to ask it to you on rounds. They're going to ask it to you in the ER. They're going to ask it to you in ICU. They're going to ask it to you on the boards. This is a focal vasoconstriction of the vasculature on chest x-ray. It's very, very rare. And I'll show it to you. It's like all of a sudden the vessel just gets cut off. You're not perfusing. Hampton's hump, absolutely know this. This is an area of a triangle wedge-shaped infarction on the lung, and it's seen all the way out in the periphery of the lung. Pellis sign. It's a prominent descending pulmonary artery. About 16% of patients get that. So I'll tell you that it's extremely hard to be able to read these. The easiest one I feel is Hampton's hump, which is also mistaken a lot of times for pneumonia. So be very, very careful for it. 16% have normal chest x-ray. So you know what I like about chest x-rays? The normals that are hypoxic, that makes me like, what's going on here? Normal chest x-ray and hypoxia. It should just ring in your brain something's wrong. Ultrasound, we could do it right at the bedside. All right, lower extremities and upper extremities, rule out that DVT. This is not my photo, but it's a great photo. And where that wedge-shaped area is, you can see how this triangle in the periphery. You started doing films, right? With Bank? So when did she teach you how to read a chest x-ray yet? I'm gonna stand back here. So when you look at chest x-rays, you want to look at it from the top down. All right, so when you look at it from the top down, all right, so you want to look at it from the top down. So what you can see here is that this patient is really not too rotated, that the clavicles are about the same height. And you want to scan your eyes this way. Now, what you're seeing here, all this white lines, that's vasculature. This knob right here is the aortic knob. This is the heart border, the aortic knob. Here's the other heart border. So your lungs, air is white, air is dark. Okay. Fluid, tissue, vasculature will be white. And you want to scan back and forth. Looks the same, looks the same, looks the same, looks the same. Something here, nothing here. Looks the same, looks the same. This is pulmonary hilum and vasculature. This is pulmonary hilum and vasculature. Looks the same. All this looks good. Heart border. This diaphragm does not look like this diaphragm, right? Mm-hmm. This diaphragm on chest x-ray should come down here. So this diaphragm looks different than this diaphragm. So if you know nothing about chest x-rays, and then you get this, you say, Mike, can you take a look at this? There's something wrong with this, but I have no idea what the hell I'm looking at. And I can help you. It's the people that say, oh yeah, this chest x-ray is fine. And you send them home, and then they die. So just be careful. So even if you don't know what this is, just be like, I don't know what this is, but there's something going on here. So this is a Hampton's hump with a right-sided pleural effusion. Both of those of which are more common with PE. And keep in mind that to have a pleural effusion, to see it on a chest x-ray, you need at least 250 cc's of fluid there.
Are any of the peripheral like vasculature like curly V lines, or this is all normal?
it's a little bit of cephalization. I'm not convinced. There's a little atelectasis right here. I don't see too many curly B lines. Students love the curly B lines. Love that. Say again? How do you know it's not rib? Was that your question? So you follow the ribs. Is this better? This is probably better. So here's your rib. Follow it. Here's your rib. Follow it. So rib is here and it goes right down. Rib is here. But what is this? So this part is actually overlying rib. But you could see this triangle area right here. That's not part of rib. Right? In that space. And here's atelectasis. This is part of atelectasis. So always follow. You could trace your ribs all the way down. So we were talking about Westmark sign. If you look at this, this is normal pulmonary hilum. See how it's round and vessels splay out from it? This isn't round, right? It almost looks like it's moth-eaten. This pulmonary vasculature just stops. It's gone. Where this one is round. So that's Westmark sign. So there's an occlusion there. Normal, round, abnormal, half round. You can't see it. It's obscured by your heart. Our heart's a little enlarged, but you can see it here. It's just hidden, but you can see it here. And you can see it here. But you can't see it here. So that's Westmark sign. So how do we diagnose patients? So now you were saying, well, why don't we just scan everybody? We could do that. Insurance isn't going to like it. Radiation isn't good for you. So there's an art to it. This is the art of medicine. But I will tell you that if you go in with chest pain, shortness of breath, dyspnea, tachypnea, coughing, things like that, and the chest x-ray is unremarkable, you're gonna get ruled out. Nobody wants to miss this. There's no reason to miss it. So there's a couple different things we could do. One is VQ scanning, ventilation perfusion scanning. This is a two-step test. There's a ventilation part of it, and there's a perfusion part of it. The ventilation part shows how well you ventilate the lung. And we utilize a radioisotope technetium in order to do this. So you inhale that and they inject it. So it is safe if you're pregnant. And then there's a perfusion. So there's the ventilation and the perfusion part. During COVID, they would not do the ventilation part. They didn't want to, everybody was so concerned that the patient's going to be breathing and all this particles going to be coming out. So we're not doing it. They would only do the perfusion part. Silly. But during COVID, that caused a hypercoagulable state, right? Those were some of the highest D dimeters I've ever seen because of that whole cytokine storm. And every other person had a PE that was in the hospital because of the hypercoagulable state. So you can do this safely if you're pregnant. You could do this safely if you're in renal failure and we can't use IV contrast in you that we would with a normal CT. You can give this if they have an allergy to IV contrast. So there is times in which we use it. Is it the preferred? It's not the preferred. It's really not. And I'll tell you why, because it's just not as accurate. We have such amazing tools now. And 10 years from now, I'll be saying that our tools are so amazing that blow away the tools that we have now. When I first started, we were doing pulmonary angiograms, which are extremely invasive, extremely invasive. So now we also utilize high resolution CT scans with IV contrast. Great, great test. I like this better. It's just as accurate as a VQ scan. Uses IV contrast. So write this down. Anybody that has an elevated creatinine greater than 1.3 to 1.5, it depends on the radiologist. But usually they won't let them at 1.5 at all, but it's really 1.3, 1.4 maybe is stretching it, but 1.3, do not give IV contrast. IV contrast is toxic to the kidneys. So if I gave you a patient that had creatinine, which is a renal enzyme that you're going to learn about in lab medicine if you ever take that class, if you have somebody that's got a creatinine of 2.5 and you're concerned about a PE, what's the test? The Q scan. Don't give IV contrast. That would be bad. There's a chance you put them on dialysis. So if not, then I would prefer CT scans. And the reason why is because you see a lot more pathology with it. Lymph nodes, masses, pneumonias, all this other good stuff that you won't catch with VQ scans. So maybe it wasn't a PE, but we found A, B, and C instead. Echo, excellent test. We could do it right at the bedside. Echoes are great. We can check for right ventricular strain, which will put you out of a small, now escalate that to a submassive or massive PE. You see right ventricular strain at submassive PEs or intermediate PEs. And you also see them on major PEs as well. You don't see them on small. You also show dilation of the pulmonary artery. You can also estimate the pulmonary artery pressure. So if you had a PE, do you think the pulmonary artery pressure is high or low? High. It's like trying to push water through a king hose. The pressure in the hose is going to elevate. So great test. And it'll also give you a good differential. It's not a tamponade. It's not pericarditis. It's not endocarditis. It's not all these other things. But you could see that it could be a PE. And depends on how much of the pulmonary artery you could see. You may actually see clotting there. Be careful of the term gold standard. All right. I don't like this. I hate this term. I feel it confuses students. But textbook wise and test wise, the tests will always follow the book. The boards will always follow the book. I don't care what anybody tells you clinically. Oh, well, we do this instead of what this said. That's great. But for the test, that's not going to be the answer. The boards, it won't be the answer. It always goes by the book for the boards. And they will use this term gold standard. Gold standard does not mean the best. Gold standard means, well, this is what we prefer to do to get the most accurate results. But that can come with a price. So that's why we really don't use dedicated pulmonary angiogram anymore. That's the gold standard test. It'll pick up PEs 1 to 2 millimeters. A quarter of the size of an eraser head. Tiny. 1 millimeter is tiny. But they're very invasive. They're very, very reactive tests, meaning a lot of people have allergic reactions to them, go into renal failure with them. They're very, very invasive tests because of the material that has to be used. And they're dedicated just to the pulmonary vasculature. Instead, what we use is CTA of the chest. Is this it? No, this is not the right. So this is not the right lecture. That's okay. Right, CTA of the chest, and put a star on that. CT angiogram of the chest. CT pulmonary angiogram is not a pulmonary angiography. They're two different tests. CT pulmonary angiogram is the test of choice that we typically use, although it's not the gold standard, but 99.9999999% of the time, it's what we use clinically, and it's the most go-to test. It picks up very, very small PEs using a CT scan. The invasive material is not used like it is in pulmonary angiogram, and you pick up everything else along with it. We could have you scanned in 5 minutes and have the result. So it's very quick, very efficient. It's tolerated very, very well. Again, if you have elevated creatinines, you cannot use it. Go with VQ scanning. It's tolerated much, much better than the gold standard of pulmonary angiography. And we do it in pregnant women. So we can give it in pregnant women. OBs, I feel, are split on this. Because if you're pregnant, I'll call up the OB and be like, can I run it through the CT? Yeah, no problem. No, please, I'd rather you not. Okay, no problem. So I'll do something else. So they're kind of split on it too. Because they feel that the radiation is so low, it won't affect the fetus and it's to the chest. Any questions with that? So if on an exam you get gold standard, go with CT, go with pulmonary angiography. If it says that the patient's got renal disease, stay away from anything IV contrast and go with VQ scan. I don't believe they'll give you pregnancy because it's a coin flip. But off the record, I will tell you that we do. Did you have a question? CT pulmonary angiogram all the time. The last time I used a pulmonary angiography, 20 years ago. That's what I mean. That's why I hate the term gold standard. Gold standard, you think like that's what you always go to, but it's not. And the book, the test will say specifically a gold standard test. So this is a very, very simple flow chart. Do you guys have up to date? I think you should see if the university was going to start giving it out.
Yeah.
What? You have it?
Yeah.
They gave it to you?
No.
Oh, you bought it yourself?
Oh, it's free. That was free.
No, that's not the right one. You got like, I'll tell you, it's not, man. Nothing is free. It's cost me like $400 a year.
No, you know what it is? I had it downloaded. I didn't log in though.
Because you can't.
I just have it on my phone.
Listen, I would see if they'd give it to you. You won't ever need a book, ever. I would find out if they will give it to you. I'll find out for you. I'll find out. You will never need a book. You can put it on all your devices. You can log in?
No. But I have it.
Yeah, it's good. So it's great resource. Everything from pediatrics to neurosurgery, everything is on there. It's excellent. So this comes right out of up to date, and it's very, very simple. All right. So again, getting to your point, if PE is unlikely or likely, if PE is unlikely and the D dimer is negative, you're done. If it's unlikely and the D dimer is positive, CT pulmonary angiogram, CTA. If it's negative, you don't have a PE. If it's positive, you have a PE, and then we treat them. You can use this Wells criteria, modified Wells criteria, came out of Johns Hopkins probably 15, 20 years ago. I'll tell you that I hate it. I don't like it. I think that it's garbage because of the way that they grade this. And they grade this on a low, moderate to high probability of having a PE. So if your heart rate is greater than 100, 1.5 points. All right, I think it should be higher because we rate people that, this is my favorite, PE is more likely than any other diagnosis, 3 points. So the tachycardic patient on PE is more likely than any other diagnosis. You know, you have to weigh that. So the way that they did this, I don't necessarily agree with it, but this is it. So heart rate greater than 100, 1.5 points. History of DVT only gets 1.5 points. So you have history of a hypercoagulable accident, you only get 1.5 points. Immobilization, you only get 1.5 points. So those three things together, I'm already not liking it. But it's up to you. I'm never going to tell you how to practice. Hemoptysis, 1 point. Malignancy, 1 point. Clinical sign and symptom of DVT, 3 points. If you come up here and I kick you in the calf, you have the clinical sign and symptom of a DVT. 3 points. PE most likely than any other diagnosis, 3 points. So you can see how I view this, but we do use it. You have to use this loosely, very, very loosely. Don't rely on this 100%. Less than 2, all right, is low. 2 to 6 is moderate. Greater than 6 is high. So if you have the last 2, you're already at 6. I like this a little bit better. The PERC rule, it's pulmonary embolism rule out criteria. You have to have every single one of these, all right, in a low probability patient. So low probability means that you're under the age of 50 and you have no estrogen use, hormone replacement use. There's a whole criteria. That'll put you into low. You're not a smoker, never had a DVT or a PE in the past. That'll put you at low risk. Basically, everybody here. This would work for you. So age less than 50, heart rate less than 100, oxygen greater than 95 on room air, no hemoptysis, no estrogen, no prior history of DVT or PE, no unilateral leg swelling, no recent trauma or hospitalization in the past 4 weeks. Every one of those is filled, the chances of you having a PE is much, much less. If you're 51, this doesn't apply. Has to be every one.
Ever? Have they ever?
No, it's current use. It's current use. Any questions with that? So this, you heard me classify PEs as small, submassive, and massive. Low risk, all right. 40 to 60% of the patients with PE, less than 1% are going to die. They do very, very well. Very well. Submassive intermediate, you will see RV strain on that echo. So get that echo. That automatically puts you into submassive or intermediate. 5 to 25% mortality rate in 30 days. Massive. Remember we spoke about that person that was syncopizing and the low blood pressures? So now they have low blood pressures. They can't maintain their MAPs, and you have to start them on pressor therapy, and it's for greater than 15 minutes. That puts you into massive risk. Your risk of death in that 30-day period is 65%. So it jumps through the roof. Thank God they're not US comments. How do we prevent them? Compression stockings, like we spoke about. If you are laid up, we have to anticoagulate you. So if you had a total hip, if you had a total knee, if you had open heart, if you had whatever it's going to be, that you're not mobile, we have to anticoagulate you. So fresh knees and fresh hips. Orthopedics love the new drugs that came out now. You know, they came out like 7, 8 years ago because they don't have to play with all the lab levels to get the heparin right, to get the INRs right for the Coumadin. Now they just write the pill. After bleeding is stopped, and have a nice day. So it's easy for them. And it's easy for everybody. But compression stockings, we can heparinize you, or you can use low molecular weight heparin. So here's the difference. And you didn't do lab medicine. So heparin activates antithrombin 3. All right, so it'll thin out your blood. We utilize the APTT or the PTT scale, and it works on the intrinsic clotting cascade. Heparin works very, very quickly. Very quickly. It's in quick and it comes out quick. It's weight-based, works very well. You could do bolus injections, you could do sub-Q injections, you could put them on heparin drips, works very well. Lovenox is even easier. Lovenox you can go home with. You could administer this by yourself at home. It's weight-based. You could either dose it once a day or twice a day. It's actually got greater bioavailability than heparin. The reversal agent for both of these is protamine sulfate. The way I like to choose whether I'm using Lovenox or heparin, because you may ask, well, why would you use one and not the other? If you have kidney disease, go with heparin. If your kidneys are good, go with Lovenox. It's easier. We can't send anybody home on heparin. You can send them home on Lovenox. They're pre-filled syringes. They come in a million different dosages. They pick them up at CVS. If you're high risk and you're not amenable to being on anticoagulation, maybe you've had subdural hemorrhages, maybe you're a chronic fall patient. Falling is a risk to be on anticoagulation. You can put an IVC filter in, inferior vena cava filter in. Do you know what they look like, what they are? You know about them? So the Greenfield filter. Yeah, so you know what it looks like? It looks like, those little umbrellas that come in your pina coladas? It looks just like that. They go in through the femoral vein into the inferior vena cava and they deploy it. And it's an umbrella that it sticks right there and it catches any emboli from the lower extremities going up. Does it help if you embolize in the upper extremity? Does nothing for you. Heparin, I don't like the way this is worded. It doesn't lyse the clot. Heparin actually makes the blood thin to be able to perfuse around the clot, and the body reabsorbs the clot. You had a question?
Yeah, what is when a Greenfield filter catches a clot?
You don't know. Nope, it'll stay there, and the body will reabsorb it over time. You won't know it.
Well, no.
You won't know. If you don't know that you have a clot, You won't know that it embolized. If you do know that you have a clot, you won't know that it embolized. The job is to catch it. It looks like to be honest with you, it looks like a screen in your window. And its job is just to catch it. And it won't go further. So if you go on heparin, then we have to put you on something else to discharge you, whether it's Coumadin or Eliquis or Xarelto or Pradaxa, any of those other medications. Are you familiar with the INR scale? Where we want to keep Coumadin levels? So no, it's actually 2.0 to 3.0. Mechanical valve is 2.5 to 3.5. The INR scale is the International Normalizing Ratio scale. And we use this scale only useful, the only time we use it is to monitor Coumadin. That's it, nothing else. So Coumadin works on the extrinsic cascade, the vitamin K dependent factors, 2, 7, 9, and 10. You could start it while you're on heparin. It takes about 5 days to reach its max potential, and we have to monitor it. We monitor it with the INR. So a normal patient's INR is usually below 1.2. It's 1.2, 1.1, 0.9, 0.5. That's not on any Coumadin. When you're therapeutic, for somebody with a PE, your therapeutic range, we want you in between 2 and 3, 2.0 and 3.0. If you're 1.7, you're subtherapeutic. If you're 7.5, you're supertherapeutic. We want you in that range. The higher the INR, the more thin your blood is. The lower the INR, the thicker your blood is. So if you are measuring somebody's Coumadin level, which most of your patients are not on Coumadin any longer because they're newer drugs that came out, and they come to you and they're there for a PE and their INR is 1.7, and you say, yeah, it's fine, continue the current dose, and they die in two or 3 days. Are you liable for that? You're liable for that because they weren't in the therapeutic range to keep their blood thin enough. So you have to adjust the Coumadin. And once we get it right, we usually measure it once a month. But it's a pain in the neck. It's influenced by alcohol, foods, green leafy vegetables, because that adds vitamin K. Vitamin K is the antidote for Coumadin because it acts on the vitamin K dependent factors. So salads, spinach, whatever. I tell people all the time, if you eat salad every single day, and I will adjust your Coumadin dose to accompany for that. But the problem is if you eat a salad on a Monday and a salad on a Thursday, your INR is it's up and down all over the place. I can't control it. Just be constant in your diet. We spoke about this. So the newer we call them DOACs, the newer medications to stop to treat PEs or DVTs are Xarelto, which is a factor 10A inhibitor, Eliquis, which is a factor 10A inhibitor, or Pradaxa, which is a direct thrombin inhibitor. And they work very, very well. The good thing about this is they're pills. You don't have to monitor it, and it's standard dosing. So it's very, very simple. For example, you're a fresh knee that just came out, post-op total knee replacement. You're anticoagulated within a couple of hours of starting Eliquis or Xarelto or Pradaxa. And I don't have to measure. Why would I use any of these other things? The only other one you don't have to measure is Lovenox, but you got to inject yourself. So Eliquis, standard dose if you don't have kidney disease, is 10 milligrams twice a day for a week. Drop it down to 5 milligrams twice a day. You do not need to know dosages, ever, for my tests. But that's just how simple it is. After a week, drop down to 5 milligrams twice a day. Have a nice day. That's it. No, come in, check your INR, go to the lab, check your PTT. You don't have to inject yourself. There's none of that. If they can't afford it, I would put them on Lovenox then, because Lovenox is just a lot easier than Coumadin. If they won't inject themselves, then they got to use Coumadin. Now, thrombolytic therapy, I'll tell you this, that if you have to use thrombolytic therapy, tenecteplase is usually what we most commonly use. These are the clot busting drugs. They should be almost dead. All right, it's a massive PE and on death's doorstep. That's when we indicate the use for thrombolytic therapy. These drugs, I don't get nervous too much. These drugs make me nervous because I've had adverse side effects. So I've TPA'd people before. tissue plasminogen activator drug using tenecteplase, and an hour later they end up with a subarachnoid hemorrhage. So now they're in the OR getting a cranie. So these drugs, they're very, very good at busting up every single blood clot in your body. So if you have an aneurysm that's being held together by the clot, it's gone in the brain. It doesn't specify the lung. It doesn't specify the clot. It specifies all clots. So if you have a little clot in your eye that's being held together and you give that, now you can have a retinal hemorrhage and lose your vision. Prolonged CPR, it's contraindicated. In pregnancy, it's contraindicated. In retinal hemorrhages, it's contraindicated. In recent brain bleeds, I think it's within 6 months, contraindicated. In uncontrollable hypertension, contraindicated. In. So if you have a blood pressure of 220 over 140, is it a good idea to give that? Not at all. So these drugs are very, very dicey, but we don't use them unless they're massive or major PEs. They're indicated for that. Would you give it if the patient had hemoptysis? You're going to bleed with these drugs. Just be aware. Would you give it? Probably not a good idea.
What do you do for a patient that's like pregnant?
So that's a great question. So my doctoral thesis, my doctorate was patients with submassive and massive PE, the outcome data of thrombectomy versus catheter-directed fibrinolysis versus systemic fibrinolysis. So if you're pregnant and you end up with a submassive or a massive PE, and it happens, what's the best treatment option? It's not this. Let's take them to the cath lab. Take them to the cath lab, you snake the catheter all the way to where the clot is, and you spray a little bit of the tenecteplase on the clot locally, it dissolves the clot. Very.
They don't.
Very. So here's the problem. Not every hospital has a cath lab, and it's very expensive. But if you were pregnant, say you're 7 months pregnant, what's the risk? Abruption of the placenta, death. At 7 months, you want to take the baby out? It's 28 weeks.
But technically, you're further than.
So let me ask you this. Let me ask you this. How safe is it to put you under anesthesia to deliver a baby with a massive PE? Not so dangerous. Mom's got to live. Mom's not perfusing. Mom's not perfusing. Take it out while she's on the table. Take it out in the cath lab. Baby will be fine. Baby will be okay.
What else can you do besides for the cath lab? Like that's it, you don't have.
That's it. Take it to the cath lab or take it to the OR.
Like if you have a cough.
So if you're pregnant, you have a risk of abruption of the placenta.
If you don't have a cath lab, then you don't have.
Is this like a what if class?
Yeah.
What if it was a full moon, all the stars aligned? What? To deal with what? Well, first you got to stabilize. I'm going to tell you this right now. Mom comes first before baby. Period. As barbaric as that sounds, mom comes first. So we have to stabilize mom. Once we stabilize mom, we have to now worry about letting mom live, the baby to live. So we're always going to try to save mom first. If you have that, you have the ability to have that cath lab, she goes to the cath lab. Don't give her the tenecteplase. You're going to throw up this scenario where, you're in the middle of Central Texas and there's nothing around you for another 4 hours that has a cath lab. What are you going to do? You're going to cross your fingers and you're going to let dad know that you may not have mother or child. It's tough, so that's not what you want. But we have a cath lab on Long Island and in the city on every corner. Thank God. Any other questions? There's a 20% chance that you end up with intracerebral hemorrhage with clot busting drugs. So if I told you I had a 20% chance of hitting lotto, would you buy a ticket? Yeah. She's like, that's a strong yes. I got bills, baby. Want to take a break? Take 5. We're gonna clean it all up.
Five.
5 minutes. We'll do plural. That's what you want to do? We'll do it. Hi.
It's your differential like.
Yeah.
They like combine these two. It makes this.
Yep.
Thank you so much.
You're welcome.
He said these things.
You're really out.
You do actually. And then you can, and then you can. And it's kind of like narrowing it down. Okay. So it's more like when you're like. You're putting.
Yeah, nothing showing up, you're like nothing's fitting.
The actor's just like here.
It's like systems of ice. Like, listen to you, that's that. We don't wanna give it. Conscious.
Right,
Yeah.
okay.
So it's just steps.
I think like the different diagnosis. Because like I was. So I was like, what are you talking? That is true. Oh, no, I understand. So I think that. I was gonna use that one. I always do.
Do it if it exists.
No problem. Somebody has CKD. It depends. How bad is their CKD?
I mean, it was just like a general, maybe like. Pretty bad, I guess.
So like they're end stage renal?
Yeah, like I guess maybe they're on like dialysis, so.
So dialysis patients aren't that big of a deal, right?
Yeah, because they're like,
Because they have kidneys, it's just a machine. So, but if you were nervous about that, I would put them on Coumadin because those other medications you have to renally dose, some of them wouldn't the criteria to be on it. No, you would just have to be careful. But if they're on that, so say that creatinine is like 2.5.
Yeah.
You know, I would be hesitant I would not use Lovenox on that patient. So I would go with the other place, I would renally dose it to 2.5 milligrams twice a day. Yeah, so you just have to be careful. So I'd either go that route or I would go with Coumadin.
Yeah.
Just the Coumadin is such a.
No, I know, I actually used to do that. To do like fine arts, there's no older.
Yeah, so you know.
Eliquis is not covered.
It's not covered, so they have to, and if they, listen, and it's like that slide I gave you, they're not gonna be able to afford it, they're not taking it.
Yeah.
But Coumadins, you see how they're all over the place.
Okay, so then the answer.
Yeah, every day, every day.
Yeah, the other fish keeps on blowing us, but obviously in the stomach.
Yeah.
Responding so much, that's why she's trying to get.
Holy. Right, yeah. I try not to use cumin in there. Because I'm spoiled now with all the new drugs.
Yeah.
You know, but if you have to, it's just, and they all get at-home monitoring, so my phone goes all the
Like,
time.
I would, no, I would think, like, I would.
Because
think, guys, I would
It's
say-
just so much easier, and I can do it in 2 seconds on my phone.
My providers have that, they would have to come in like weekly or like one every.
Yeah, I'll show you, like I have, happens all the time, like this is what you shouldn't do, but I do it all the time, like,
Right.
Yeah.
you know, it's all the time. You know, so it's safe. So if they want to be on Coumadin because they can't afford it, they get an at-home monitor. Don't come into, well, that generates money.
Yeah. So
It generates income. But the problem is that I don't want to be bothered with it. I really don't, like, send them to a Coumadin clinic and the Coumadin. Yeah, it's just, I'd rather, the only problem with the at-home monitors is you have to do it once a week or else insurance won't pay for it. Yeah, yeah, it's always something, so. What's up? Why if they're ACL? Oh, ACL. Okay, you mobile. You mobile. Walking?
Yeah, no, thing on that, it was like a 2 month. I'm curious.
So, for the criteria is, as long as you can walk on, you can, if you're mobile, you want to 100 feet. You don't have to go. So those patients with hips and knees, we want to stay in bed. So, and you have a value where your husband's ACL, he's probably up and walking that bed. But as long as he's mobile, he's good. Oh, no, you know, 100. No, they have to be anti-coagulated. Even if they're had the hip and knee done, they're gonna be. He's still walking. But ACL. How far do they ambulate? Like if you're getting up to ambulate from here to there, it's not enough. It's not enough. Like you really want to be like able to walk on crutches. You know, if you can ambulate 100 feet, get up, walk to the bathroom, walk to the den, walk to the kitchen, go back, sit down, go outside. You could do that. You don't have to. Some orthopedics will put you on aspirin. He's a young guy, low risk, and he was walking with the crutch. He doesn't really have to. He doesn't really have to. You don't want to be on it. You know, it's definitely bad. Like I'm a minimalist when it comes to that. So, but young guy for his ACL, if he can ambulate, let him ambulate. Plus, was he in the CPM machine?
No, I figured they did want to. Literally, no, I can't look at it.
I'm sure he can't look at it either. Like, help people take pain medicine and jump on that thing. But that's doing this, right? Yeah. 100%. So he doesn't. You're welcome.
Stasis. Right, I like also like in general. Once they're an athlete, cost. Exactly. That's how you.
You just.
Back to the first, actually, I thought, second. Well, the relative back. That was PD vital sign. Vital.
I love that you have this much faith. I love that.
All right, ready?
It really, it like.
All right, so, well, yeah. Pleural effusions. This is super simple. Again, I'm going to tell you what you need to know on this and what they're going to ask you. What? Well, I'm different. I'm not going to tell you what I'm going to ask. Of course, I'm going to tell you what I'm going to ask. But they will ask you, like, you'll have some preceptors that they just want to pimp you. Like, I just find that to be too much work. I was like that, and I just like got burnt out. But I will tell you what you need to know, and keep this very, very basic. What is a pleural effusion? An effusion is just a fluid buildup. All right, and it's going to be fluid buildup within the two layers. The two layers in our lung are the visceral pleura and the parietal pleura. Lymphatic drain against the parietal pleura. All right, and we always have pleural fluid being made, always at all times. It keeps everything nice and viscous in there. It keeps things gliding. So we always have it. The problem is when you have too much of it building up in the chest. Did you do this in physical diagnosis yet? The egophony, all that stuff, and then you percussing, and I'll be the first to tell you, I have not percussed one patient since I probably graduated. And the egophony, I've never done it. I think I failed that in PA school also. But you will be able to hear. You can definitely hear it. All right, and this is all dependent on the hydrostatic and the oncotic forces. So a little bit of physiology. So when your oncotic forces get too low and your hydrostatic overcomes that, what happens? You're going to spill into the empty space. Okay, and that's where the problems lie, right there. We see them all the time. 1.3 million cases a year. I think that's even low. I think I see 1.3 million patients a year with this alone. It's just ridiculous how many people have it. Your job is to determine, one, is it transudative or exudative? Two, how are we going about treating this and being able to pick it up? And three, how much further do we work this up? There are 5 major types. Transudates, clear. They are crystal clear, transudates. Exudates, not clear. Empyema, which is what? Pus. Hemorrhagic, which is bloody. And chylous, which means what? Lymphatic fluid, exactly. Is lymphatic fluid going to be clear? So if you have any of these, it's going to be an exudate. Unless it's clear, it's most likely a transudate. So if the fluid that you drain out of their chest with a chest tube or a thoracentesis is straw colored, it's likely going to be an exudate. If it's clear, it's likely going to be a transudate. If it's green or bloody or white, it's an exudate. So it makes it kind of easy. But we always have to classify them as transudates or exudates. This you need to know. Just know this. This is the most important slide on the whole thing. You can go to sleep after this slide. All right, so you need to know the pH, 7.6 to 7.64. Above or below that is going to end up being an exudative effusion. Protein content, less than 2%. So it's got a very low protein content. Very low white blood cells, so less than 1,000. Glucose, similar to that of our serum. So if you're running at 70, this should be about 70. LDH, less than 50% of the plasma. Sodium, potassium, calcium, all that's the same as plasma. So that's normal pleural fluid. That'll be seen with a transudative effusion. Exudates are going to have the following. Pleural fluid protein to serum fluid ratio of greater than 0.5. Pleural fluid LDH to serum LDH of greater than 0.6. And the pleural fluid LDH is greater than 2/3 the upper limit of serum LDH. So you have to draw that blood test. If you have those, you have an exudate. Transudates don't have any of those. Transudates at the top, exudates at the bottom. This is called Light's criteria. They will ask you this. And out of all this that they're going to ask you, they're going to ask you pH, white blood cells, and these 3 bullets. Transudates, most common cause, heart failure. 500,000 cases. Nephrotic syndrome, cirrhosis, peritoneal dialysis, superior vena cava syndrome, pericarditis. This guy right here, pulmonary embolism, falls into both. So it's not reliable. It can be exudative or it can be transudative. It can also cause hemorrhage. So it can go either way. Exudative. When you think of exudate, you think of like pus on your tonsils, pneumonias, right? Infection. Not only bacterial, but also viral. Cancers. Common cause for chronic recurrent exudative effusions. PE, again, 150,000. Empyema, which is abscess formation in the lung. IV drug abuse is very prone to that. TB, viral infections, fungal infections. What's rickettsial infection? Rocky Mountain spotted fever, right? So tick-borne diseases. Asbestosis, sarcoidosis, post-MI, very common. Infarcted or had open heart, very common to get effusions after. So empyema, well, if it looks like pus, it probably is pus, so it looks like pus. It's thick, it's turbid. Hemorrhagic, going to look bloody. Serosanguinous can also look that color. Malignancy can bleed very easily into the chest as well. PEs can bleed. Pilus can be different, where you have a hard time determining if is it just an exudate or is it chylus? Is it empyema or is it chylus? Which one is it? And the simple way to do that is when you drain this, you put it into a tube, throw it in a centrifuge. If you spin it and it separates, it's not chylus. All right, it's empyema. Chylus will not separate. So symptoms, you need about 250 cc's of fluid to be able to see it on a chest x-ray. CAT scans pick up minimal, and really just physiologic in nature, all the way to these large massives. So you may have no symptoms whatsoever if it's tiny. Dyspnea, shortness of breath, cough, dullness of percussion. Very large effusions can cause tracheal shifting. There's that agophony thing. Let me see if I could show you guys somebody that I have right now. Pick up this chest x-ray view. So lab-wise, so we already discussed how we could see it on chest x-ray and CT scan. But lab-wise, how do we know what it's made out of? You stick a needle in it. You could do a thoracentesis. You can aspirate it out. All right, so CT scans are so small. Chest x-rays, you need 250 cc's, know that number, and love that number to ask. I don't know why, they love it. Always send that fluid out for a test. So have it analyzed. So when I drain somebody, I send out that pleural fluid for cytology to see if there's malignant cells in there. For analysis, they'll analyze it. They'll give them the pH, if there's amylase, lipase, the protein, the red blood cells, the white blood cells, they give you all of that. And always send it for culture because you'll be able to see if there's bacteria in there. So if you have a pneumonia that has an effusion and you drain out that effusion, you can see exactly what the bug is. Spoke about this. I don't think that this is really important for you to know of what less than 7.3, greater than 7.65. Just understand that anything outside of transudate will whack out the pH. Cancers, you can get lipase and amylase in your chest from acute pancreatitis. It's very, very common. The thoracic duct drains into the left side of the chest, so it's very common to get left-sided effusions with acute pancreatitis. Esophageal ruptures will cause amylase to go into the pleural fluid. Cancers, we can see exactly what type of cancer we're dealing with. And how do we treat them? Well, we always treat the underlying process. So if you have bilateral effusions on somebody and they're in congestive heart failure, is it a surprise that they have bilateral effusions? No. How do you treat it? Well, first we always try to diurese them, right? We try to diurese them. If they don't respond to the diuresis or they're extremely short of breath because of the effusions in their chest, if they're very, very short of breath, drain them. If they have moderate to large effusions and they're very short of breath, drain them. If they just have small to moderate effusions and they're stable, try to diurese them. Try not to stick a tube in their chest. Diurese them with IV Lasix. So treatment of the underlying process, right? Treatment of the CHF, most likely you'll get rid of it. If not, you have to drain them. Pneumonia. Pneumonia with an effusion. That's called a parapneumatic effusion. How do we treat it? Cool the pneumonia. The effusion usually goes away. If the effusion builds, drain it. Malignant effusions are a little tough. Radiation is good for that. Obviously, removing the mass is good for that. But what if they're not a candidate? So that's where the problem begins. You may try to put long-acting chest tubes in, called Pleurex catheters, which could stay in for a very, very long time. They can drain themselves at home. It's on a valve. They just drain themselves. Resection of the tumor, radiation to the tumor. You can also do what's called a pleurodesis, where with a video-assisted device, it's called a VATS procedure. Have you heard of VATS? Video-assisted thoracoscopy. It's a scope that goes in between the visceral and the parietal pleura. And you scrape it up. You drain them, you scrape it up, and that scraping causes inflammation, which causes the two pleural layers to weld together. That way they can't form fluid in between there. We spoke about this. The problem with parapneumatic effusions is that although you may kill the bug, all of that loculation could stay in there. So that fluid gets thick, almost like a cottage cheese type consistency. Can you drain cottage cheese through a needle? No. So you stick in a chest tube. And then what you do is you shove 60 cc's of saline in there and rip out 60 cc's of saline through the chest tube, and you're not getting much out of it. Then they have to operate on them. You have to do a thoracotomy and actually scoop out all of that. So again, on your chest x-rays, your diaphragm should come all the way down here. You should have at least 10 ribs in a chest x-ray. And you can kind of see where it comes down. You can see the shadow right down here. You can see the shadow coming right down here. So you could kind of see that shadow here. So if you need 250 just to hit this line right here, how much do you think is here? There's a minimum of 500 cc's here. So if you look at this person has bilateral interstitial infiltrates. This is COVID pneumonia with bilateral pleural effusions. Small to moderate bilateral pleural effusions. You don't have to be good at reading chest x-rays to see this, right? I told you, fluid is white, air is black. So totally whited out left lung. This needs a chest tube. This needs a chest tube, right? Just put the chest tube in. Deal with everything else in. So this is a patient with COPD. You can see how elongated the lungs are. And what you're looking at is, it looks like a meniscus, right? That's how you could tell that the patient's got an effusion. The meniscal lines, the diaphragms are not sharp. They're not down to here. They're filled with fluid. They're humped or a meniscal line. And that's how you could tell that they have a pleural effusion. And on the lateral, this should come all the way down here. But you can see, so from this point here all the way up, there's your meniscal line. Large right pleural effusion, I would drain this. Small left pleural effusion, you can see how the costophrenic angle comes all the way down. See how this one is blunted here. Large left effusion. Any questions with effusions? How do I get on to, no questions with the fusions? How do I get to? So that's your fluid line. So see this, that meniscal line here? That's your fluid. So that's a fluid. That's just showing you fluid here, air here. That's the line differentiating that. Now, if you left this person on their left side and shoot the chest X-ray, laying on their left side, this fluid will actually seep here, where gravity is. So all this fluid that's down trapped in here, it'll actually ride along the left side of the lung. How do I get to the other lecture? We'll do pneumothorax. You guys have another class after this? No. Can't wait to get out of here. It's been a day. It's been a day. What do you have? You want to? Do you want to do this lecture at a different time?
Matter so far.
Do you want to end in?
Let's do 20 minutes. Let's do 20 minutes.
All right. I'm just trying to let you go. All right, we could do it.
No, come back.
It's just gonna end.
All right, whatever you want.
Very.
I'm a considerate kind of guy. All right, pneumothorax. So simply just a collapsed lung. That's all this means. Please don't confuse this with atelectasis. All right, that like makes my head spin. When I get these medical students, they're like, oh, atelectasis, collapsed lung. I'm like, get out. Just get out. Don't even come back. All right, so you have different types. Everything is broken down in medicine, as you can see. It makes you nuts. You have tension. You have traumatic, secondary spontaneous, and primary spontaneous. And what is happening is you're getting air trapped in between the visceral and the parietal pleura, and it's pushing your lung down. It's collapsing your lung. If you cannot expand that lung, what happens to your breathing? It's kind of common sense, right? You're going to have decreased breath sounds on that side. You're going to hyperventilate. The pleura is very, very painful. It's got a lot of pain receptors. Will you have pain on that side? You're going to have pain. Will you get tachycardic? Will you get tachypnic? Kind of sounds like PE, right? So they all kind of sound the same. Primary spontaneous. When you think of this, so primary means there's no underlying cause for it. And spontaneous means it just happens. So think about your tall, thin male smoker, 15 to 30 years of age. That's who typically will get this. And a lot of times this is caused by rupturing of cystic apical blebs, which you may have them and live until you're 110. It's not a big deal. Sometimes they get inflamed or grow too much and you can collapse a lung. So half of all of these guys, most common, well, it can be girls too, but half of all these patients will have reoccurrence. It's because of their body structure. Secondary is caused by something. Pneumonia. Iatrogenic means you did it. You actually kind of list that under traumatic. Cystic fibrosis, COPD, asthma, menstruation. You may think, how is that even possible? Catmeal pneumothorax is when patients with endometriosis have endometrial tissue lining their diaphragm. When they menstruate, it gets inflamed and they drop a lung. So I had a case of this in the city where she was coming in like once every 3 months with pneumothorax. Like, it's like your third chest tube in like 9 months. Like, what is the deal? And went in with a VATS procedure and she had endometrial lining all over her diaphragm. So simply just resect the endometrial lining. She did well, but also did a pleurodesis on her because endometriosis typically reoccurs again. And she was young. We're not going to do oophorectomy on her. And she did well after pleurodesis. But we took out all of that endometrial tissue on her diaphragm. PCP, which is pneumocystis travorsi, also known as pneumocystis carinii. It's an opportunistic infection that HIV patients get. About 1 to 2% will end up with pneumothorax. Traumatic, no surprises here. It's trauma. Whether it's a car accident, whether you get hit with a baseball bat in the chest in a fight, whether you fall off a roof, it's trauma. All right, so they're all traumatic. They could be closed or penetrated. So an ice pick into the chest or a steering wheel column into the chest. Yep, both examples of traumatic. All right, whether it's open or closed, you would just have to signify that it's an open traumatic pneumothorax or a closed traumatic pneumothorax. And again, we could cause this as well, central lines. Now with sonogram, it's not as common, but back in the day, it was you didn't do enough central lines until you caused a pneumothorax, because central lines run right along the apice of the lung, and you advance it, and you hit it, and you collapse the lung. It happens quickly. Is it malpractice? It's a consequence of the procedure. It's not malpractice. Malpractice is missing a PE. They'll get you on that, but it's not really malpractice. Biopsies of the pleura, bronchoscopies, you vent somebody. This is where you can get tied up in malpractice. You intubate somebody and you vent them right away, and you didn't check placement of the tube, and you intubated the right main stem bronchus, and you hook them up to the vent, and you explode their lung. That's going to be malpractice because you didn't confirm the placement. That's a problem. Can it fix it? Yeah, you can fix it. Is it a problem? Yeah, it's a problem. All right, this is central line. Everybody see a line? So if you're looking at this x-ray, you remember how I said the clavicles are even? Are the clavicles even here? Look at the head of this one going straight across. Not even close, right? Here's the head here. Here's the head here. So this patient's rotated. So it's a rotated film, which kind of screws up your film because everything else rotates with it. But here's your central line coming in. And we look from the top down. How do these look? Who knows what the diagnosis is? Who needs a lifeline to call me? What's the diagnosis? What? Right-sided pneumothorax. So when we're looking at chest x-rays, remember I told you air is white, air is dark, fluid is white, or tissue is white. Why is this all black here? It's all air. You don't see that here, right? So we're always looking for something called a companion line. See this line right here? That line is your lung. You're always looking for the companion line. The other way that you could, if you want to be sure, do the vessels go all the way out to the chest wall here? Do they go all the way out to the chest wall here? That's the way you can tell that you have a pneumothorax. Okay? So a large right-sided pneumothorax. Small as anything less than 2 centimeters. All right? Or about 15%. Is this more than 2 centimeters? 2 centimeters is about here to here. I would say, yeah, it's a lot more. So this is a large right-sided pneumothorax caused by the central one. Now with ultrasound, like I said, we very rarely do this, but it happens. Tension. Tension pneumothorax is a medical emergency, and this is what we really worry about. The tension pneumothorax, let me explain this. When you inhale, all of that air that you inhale gets trapped into one side of the mediastinum. When you exhale, it won't release and come out of that side of the mediastinum. So every time you inhale, it gets trapped. You can't exhale it. So every time you're inhaling more and more air into the mediastinum. It grows more and more pressure in the mediastinum. What does it do? It pushes the lung and the great vessels and the heart over to the other side. So you get circulatory collapse with this. So if it's on the right side, you're going to cause right-sided restriction, inability to perfuse from the right side of the heart. Left side is going to compress the left side of the heart. And you also compress the great vessels. You get tracheal and mediastinal shifting. So this is a medical emergency. This is not the kind of thing where we actually have, let's take 15 minutes. Let's put the patient in Trendelenburg. Please get the sedation. Please hook them up to cardiac monitor. Can I get 2 nurses to help me? And after they're all done talking, and then put a chest tube in because they die by that time. So this is a medical emergency, and chest tube is not the treatment of choice for this. So don't get it wrong on the test. All right, so again, life-threatening. So symptoms, chest pain, dyspnea, tachypnea, tachycardia, decreased or absent breath sounds on that side, mediastinal shifting with tension pneumothorax. You're not rising that side of the chest appropriately when you inhale. Tracheal shifting. They easily go into respiratory failure on you. I wouldn't worry about the blood gases. It's going to make much more sense when we do blood gases. We'll do blood gases next week. It'll make much more sense, but they're going to hyperventilate and they're going to make themselves alkalotic. They'll end up with a respiratory alkalosis, but don't concern yourself with that right now. It'll all make sense next week. EKGs. Can you have EKG changes? Yeah, if you cause any mediastinal shifting, any prominence or impediment on the great vessels or the tissue of the heart, yeah, you can get ST and T wave changes. So you can have non-specific changes with a left-sided pneumothorax. Chest X-ray, always looking for that companion line, which is diagnostic. If you have fluid in there, you can have a hemopneumothorax or a pleural effusion at the same time. Not uncommon to have both at the same time. A deep sulcus sign, which I will show you this. This is an abnormal radiolucent claustrophrenic angle, and I'll show you that. Differential, easy. MI is an easy one, right? PE is another easy one. Pneumonia is easy. Aortic dissection. They're all easy. Those are easy ones. Pleural effusion can be another one. You name it. Esophageal rupture could be another one. Diaphragmatic rupture can be another one. So treatment all depends on the size. Not everybody needs a tube. Not everybody needs a thoracentesis. Not everybody needs a chest tube. You guys know the difference, right? Thoracentesis is a needle that goes in and we can aspirate out. Chest tube is actually a tube that goes in and we hook it up to water seal drainage. So if less than 15% or 2 centimeters, this is not updated either, put 2 centimeters up here. We can observe those people. So if you have a spontaneous pneumothorax, you're running, you're going out for a jog, and all of a sudden you have extreme chest pain, difficulty breathing, you come in, we shoot the chest x-ray on you, you have a very, very small pneumothorax. Do we have to put a chest tube or do a thoracentesis? It's less than 2 centimeters or 15%, we can observe you. We're not sending you home, we'll admit you, and we keep doing serial chest x-rays. If by the 3rd day it doesn't expand, we try a thoracentesis. If that doesn't work, you may need a chest tube. If it's recurrent in spontaneous, and we do this not just for spontaneous, we do it in many different issues. Again, a VATS procedure, it's a video-assisted thoracoscopy where you put in a scope in between the chest wall and the lung, and this has a tiny barb on it. You scrape it up, and it'll make the visceral and the parietal pleura stick together. It glues together. It's extremely painful when they wake up. They'll be admitted, and it works very well. That is almost curative. Back in the day, 20 years ago, they used to also put talcum powder in there to make it glue together. We no longer do that anymore. Secondary spontaneous, more life-threatening than spontaneous because then you have other issues at hand. COPD, pneumonia, heart failure, whatever it may be that's going on. So now you're dealing with 2 things, but typically tolerated well, usually treated with chest tube. Traumatic, again, traumatic. You get into a car accident and you're ejected, you break 6 ribs on one side, you're getting a chest tube, if you have a pneumothorax. If you have a hemopneumothorax, that means you have blood as well as a collapsed lung in that mediastinum, and you end up with 2 chest tubes, one in the base, because blood will sink with gravity, so put that tube in the bottom, it'll drain the blood out, and one inferiorly, to drain out the air to expand the lung. And like I said, the tension is a medical emergency. You don't have time to put a chest tube in, all right? So this is a medical emergency, and the patients die from lack of perfusion. If you don't perfuse, blood, which carries hemoglobin, which carries oxygen to tissue, it dies. So you want to relieve that tension in pneumothorax as fast as possible. The treatment of choice is a large bore IV. All right, so it's a large gauge IV, usually about 14 gauge in adults, 18 to 20 in pediatrics. Second intercostal space, midclavicular line. So betadine prep it and put the IV right in. You could pull the IV out. Don't keep your face closed because you're going to get a gush of air and blood that comes out. You'll get a gush of air that comes out. You take the needle portion out of the IV. The angio cap will stay in. Everybody knows what that is, right? Right, the rubbery part stays in. Take the needle out, sew down the catheter, and it comes. We have these valves. They're called stopcock valves. We screw them onto the end. You can close it off. Close it off. They'll breathe normally. Then put your chest tube in. If they're getting short of breath, open it up, let the air out, close it off again. Once your chest tube is in, hooked up to water seal drainage, and then you confirm it, then you take that needle out of the chest. All right, don't take it out until that chest tube is confirmed in a good place. All right, so what do you see?
Right side, left-sided.
I gotta go back. What is it?
Left-sided pneumonia.
Left side of pneumothorax?
Left side on the top, left side darker on the top left. So that's diaphragm, okay.
Why is it so much higher?
So this is actually an elevated heavy diaphragm here. So which diagnosis? Is it right side? Who says right sided? No? Who says left sided? Who says bilateral? Who says it's a pneumothorax? Who says it's a tension pneumothorax? Who says it's a spontaneous pneumothorax? This is a left-sided tension pneumothorax, and how do you know? Look at the trachea.
Oh, it's deviating up.
Trachea is on the wrong side of the chest. Look at the heart. It's on the wrong side of the chest. That's your heart port. This is your heart port. That should be over here. Here's your mediastinum. It's on the right side of the chest. It's not midline and to the left. Your aorta is dropped at center. It usually comes to the left. So that's a tension. Shifting everything left and compressing left. Here's your companion lines. Right here. All dead space, all dead space. You see how this is the one thing of this costrophrenic angle here, that radiolucent, that's your deep sulcus sign. It's not sharp. What is all this stuff? Shrapnel? Snaps. That is the left side.
I'm at the right side.
Nothing. It's just that everything is pushed over onto the right. The whole heart mediastinum is pushed over to the right side. That's how you know it's a tension. This is all normal. They have an elevated right hand diaphragm, but that's so patients typically do very, very well with this. If they have reoccurrence, I would suggest that they do the pleurodesis, and it's very, very good. This is for tension pneumothorax. This is that stopcock valve that I was talking about. So this is part of the ventilation bag. This is the angiocath, second intercostal space, midclavicular line. And from here up is the valve that you put on. That valve, you can open it and close it. Lets air out, close it off. Take a short of breath, open it up again, it'll let air out. Don't remove this until you have confirmation placement of your chest X-ray. You can see your companion line right here. So this is a right-sided pneumothorax. Is this a tension or is this a regular pneumothorax? Regular, right? So nothing is shifted to the left. Trachea is midline. Can you tell if this is traumatic or spontaneous? Can't tell. You need the history. What do you see? Huge pneumothorax, right? So basically the lung is gone. Right, little bleb all over here. Here's your cardiac water. If you said left side pneumothorax, you're wrong. Here's the mediastinum. Here's the heart on the right side of the chest, and here's the heart going towards the right side of the chest. This is the tension pneumothorax, not a pneumothorax. What's the treatment of choice? Chest pain.
Oh.
Needle decompression, and then chest tube. You gotta remember, chest tubes are gonna take a little while to put in, right? You have to sedate them, you have to hook them up to a cardiac monitor, you have to get nursing, you have to get an intubation tray, chest tube tray, you have to cut them, and we'll talk about how to do that. CT scans, right-sided pneumothorax here, small left apical pneumothorax up here. That's a close-up of your companion line. See white in here and all dark. So this is all your dead space. Here's your companion line on the left side. A lot of people confuse this with the scapula. It's not the scapula. This is your companion. Going back, I just want to tell you how to put a chest tube in. So again, you have to sedate these people. You have to be permitted to do sedation, which you will be if you do critical care or emergency medicine. And it's up to you what you like to use. Propofol, narcotics, or benzodiazepams. It's totally up to you what you like. A lot of people use morphine and Versed. I like propofol, but you have to have nursing there, hooked up to an EKG monitor, ready to intubate them in case they go down. You need the ET tube tray and the chest tube tray. So you put them in 30 to 60 reverse Trendelenburg, which means this is Trendelenburg. This is your head down is Trendelenburg. Reverse Trendelenburg is head up, 30 to 60 degrees. It would kind of be weird to be cutting into their chest if they were upside down. Again, sedate them. I don't go skimpy with sedation. All right, but that's up to you. 3 to 4 centimeter incision over the 5th or 6th rib, mid-axillary line. We always want to do our incision over the top of the rib, not underneath. There's a nerve, artery, and a vein that runs underneath each rib. All right, they could do nerve blocks in that area, but you don't want to damage that. You don't want to damage that. So everything should ride over the rib. The cut is over the rib. The incision's over the rib. After that, what I do is I bluntly dissect with a Kelly clamp or a curved clamp. I bluntly dissect away. Then you're going to come to cartilage, intercostal cartilage and muscle. Puncture through that. Again, don't keep your face close. You're going to get blood and air that gushes out of there. Puncture through it, you're going to get a large spurt of air. Their oxygenation is going to go up. Put your finger in there, sweep all the way around. Your traumatic patients could have diaphragm, bowel, there could be shrapnel in there, whatever it may be. You want to be sure that you get at any foreign body, and you don't want to hit any bowel or anything going in with the chest tube. Take the clamp, push through it your finger over the rib, and then take the hose, clamp the hose. The tube is long and it's perforated all the way through. So if you insert that and they're bleeding, the blood is just going to start pouring out of all the perforations. If you clamp it, it won't allow air to suck blood out of the perforation. So clamp the bottom of the tube, insert the tube, have the tube inserted, put it a couple centimeters past the end of the perforations, about 5 centimeters. Sew it down. So I like silk for this. You do a special sewing technique. You wrap it around the tube and sew it to their chest wall. They're going to get agitated. They pull everything. You don't want them pulling it out. So they won't be able to pull it out when you sew it down. Then you take Vaseline soaked gauze, or what we call Zeroform, wrap it around that, and then put a bulky dressing so air won't leak out. Get your chest x-ray, confirm the placement, and hook it up to water seal drainage. So again, that's the incision over the rib, bluntly dissect, going over the rib. So again, this is the cross-sectional view, but you're going over the rib. There's your nerve, artery, and vein. This is what you don't want to go near. So over the rib, and then you hook it up to water-sealed vacuum. It'll drain out fluid and it'll drain air. And they have a whole, but all the pleurovacs are different. They'll do the same thing. And we spoke about needle thoracoscopy. Any questions with pneumothorax? Go ahead.
Actually, a question about chest tube. So when
Yep.
they say they're gonna put in a big.
Pigtail is different. So pigtail is a type of chest tube. So pigtail is a catheter about that long that we can put in. It's all perforated. And the tube on it, and we'll send them home with this. You could send them home with this. The pig on it, the tube on it wraps up like a pigtail. And you just put a dressing on it. And then when you feel like you have to drain them, if they have recurrent effusions or malignant effusions, you pull it out, it unravels. It's got a little valve on it. You drain it out, close it, and then it curls back up again. You just put a dressing on it. That's a pigtail. It's also a pleurex. So that can stay in there for a while. They're very useful. So malignant effusions, recurrent effusions, you're welcome. After 2, my limit is 2. If I have to drain you more than twice, you get that. You're welcome. You too. Good luck on your test tomorrow. Oh, you have another day. I don't feel that bad for you. Go ahead. Where? This here? It's a good pickup. If you picked up that and that, right? Yeah, that's the fraction. Yeah, that fraction. You're welcome. Shoot, go ahead. Yeah.
Was something like in there, like, that wouldn't cause any worse damage.
No. So bowel is very forgiving. Diaphragm, you're gonna feel the diaphragm, but you want to be sure that you don't, because you can, you rupture your diaphragm, you can have full bladder up there, pancreas, pancreatic head, stomach, small bowel. You're like, what is that?